Good evening, everyone, and thank you so much for joining our webinar tonight about uncertainty in offering and accepting an organ, sharing a decision. And I would like to start with introducing my co-chair tonight, David Paredes. David specialized in nephrology and internal medicine at the Pontificia University in Bogota, and he later took his PhD at the University of Barcelona. And he's currently working as a consultant in the donation and transplantation coordination section in Barcelona, and he's also an associate professor at the surgery department at the same university. He's also a member of the board and a previous chair of the EDCO, which is the European Donation and Transplantation Coordination Organization. And I'm very glad to be hosting this with you tonight, David.
Thank you so much, Peter. For me, it's a great pleasure to be together with you. Good evening to all the people and welcome. Peter is a very good friend from Sweden, and he's the founder of MOD. More Organ Donation is a new type of patient advocacy network in Sweden. And Peter received a kidney transplantation from his mother 11 years ago, and yesterday has been his anniversary. So congratulations, Peter, for you and the kidney, okay? That's wonderful, it's wonderful. And now Peter, he becomes very passionate about including the patient perspective on issues relating to organ donation and transplantation. So please, Peter, go ahead and give us an explanation of the webinar.
Well, as everybody knows, all patients suffering with any type of illness has to cope with a degree of uncertainty and lack of knowledge. And dealing with this, particularly when it comes to transplantation, we know that that's one of the key priorities, both while you're on the waiting list, but also after you have received a transplant. But that uncertainty is also true for the transplant professionals working with us. So today's seminar will focus on this uncertainty relating to the donor from a perspective of both the patient, but also from the professional. And I'm really looking forward to this. And this webinar is part of a longer learning journey, which started in this spring, in April, where we had a webinar about coping with uncertainty during the COVID-19 pandemic. And after that, we followed up with a survey in the patient community around Europe to kind of figure out and ask you what the main concerns are for us as patients in this situation that we are today. So the Transplant Learning Journey 2.0 is part of a learning work stream, and it's been part of a group from the ESOT leaders together with representatives from the patient organizations. And we will also, we had a webinar last week that focused on how long will I wait, understanding the uncertainty on the waiting list, as you can see here mentioned. And today night, we're having the topic about uncertainty in offering and accepting an organ, sharing a decision. And then the next part of the learning journey is this program, which is now in 10 days from now, which will focus on fear of graft rejection and also follow up on another survey that we have made and looking at from what the patient perspectives is on these important issues for us: uncertainty in illness, impact of the patients. And we would like everybody invite you to register. And we would also like to mention that for all transplant patients and members of organizations, we have a specific fee for you guys. So you're more welcome. And I would also like to know a little bit about, because we're so happy about everybody that are joining us tonight. So we would like to start a smart poll to see who's joining us today. We had about over 100 people register, but we want to know actually who is, we want to know more about you. So I would like you to fill out the poll that appeared on your screen. So we get to know you a little bit more. Are you an organ recipient? Are you on the waiting list, or will soon be maybe? Are you a healthcare professional or medical doctor, or are you a healthcare professional with a transplant coordinator or a nurse or some other type of healthcare professional? Please do fill this on your screen, and we will. I'm awaiting with anticipation to see who's joining us tonight. Okay, so we have a large degree, some 50% over from the healthcare professions, but we also have people on the waiting list and recipients as well. We're actually not so many on the waiting list, I apologize, but we have organ recipients and a lot of healthcare professionals, and you're all welcome tonight, and I appreciate you all joining us. And now I would like to turn over to David, who who's going to present the program as well as the speakers.
Thank you so much, Peter, for being so kind and for all the attendees to join us. This is wonderful to share this program. And first, we will have four different types of presentation from the clinician perspective with Hannah Mappel from UK. Then Daniel Gallego is from the patient perspective from Spain. It's a nice, interesting title, The Responsibility of Offering or Accepting an Organ. And then we pass to Gabriel Oniscu from UK on the clinical perspective about what to do and when you don't have a crystal ball. So it's to reduce uncertainty and communicating with the patient, very essential point. And then we come back to Angelica with him from Germany, from Austria, from the patient perspective. And at the end, we invite all of you to the Q&A session at the end to submit your questions in the Q&A box of the Zoom interface at any moment during the webinar. So we can, if you like to specify to which speaker you would like to address this question, it will be great for Peter and for me to facilitate answering this question. And please, Peter, be so kind to introduce the first speaker. That will be Hannah. Please be so kind.
Yes, Hannah, please, you can share your slides as I'm introducing you. Hannah is a transplant and general surgeon in the final year of her training at Guy's Hospital in London. She's a clinical lecturer and research interest in the health psychology as applies to healthcare and transplantation. She has a specific interest in unspecified living kidney donation and rehabilitation of patients who are on the waiting list and of a transplant. She's the vice chair of the LPAT, the section of ESOT dedicated on ethics, legal, and psychological aspects of transplantation. And I'm really looking forward to talk about could, would, should, inside the mind of a transplant clinical at the time of organ offering. Please, Hannah, take it away.
Thank you very much. Okay, it's my conflict of interest statement and just a note on social media. So let's talk about uncertainty. So as far as I'm concerned, I think transplantation as a specialty is fairly unique. And one of the reasons for that is because it involves more than one person. It involves a donor and a donor organ. And by that very nature, all transplant organs are second-hand. And as a result of that, we have lots of different factors that we have to consider when we are offered a potential organ for somebody. Unfortunately, uncertainty can be quite a big part of this. And I think one of the main things that I think about is just because I can do something doesn't necessarily mean that I should. So just because an organ is on offer doesn't necessarily mean that I should definitely transplant it. As I mentioned in my talk last week, I think a lot of the issues that patients come across is related to the type of organ that they're waiting for. If you're waiting for a heart, some lungs or a liver, there is a much more immediate threat to life, and therefore time is much more of an issue. When you compare that to kidney patients who have options of living donation, dialysis, it may be slightly less life-threatening. However, having a chronic illness and waiting on the waiting list for a longer period of time then tends to be more of an issue. And as a result of that, the risks can be different. And as well as thinking about the risks of having a transplant, we also have to think about what are the risks of that person not having a transplant, because staying on the waiting list carries its own risks itself. So the way that I tend to triage organ offers when I get a phone call when I'm on call is I think about, is this an organ that I would say no to regardless of who the recipient is? Is this an organ that I would say yes to for pretty much everybody? I think, unfortunately, these offers are relatively rare. An example that springs to mind is if you get offered a living donor kidney, say from an unspecified donor, and these organs really are considered a bit of a golden ticket and very, very rarely are turned down. But more often than not, it's a case of relative risks and benefits. So is this organ that I'm being offered for this particular recipient the right organ for this person? And typically we think about 3 different things: donor factors, recipient factors, and also other. And I'll just go into these in a bit more detail. So in terms of donor factors, we want to know a little bit more about that individual, what their past medical history is like, what blood tests and other indicators do we have in terms of how that organ is working. How has this person reached the end of their life, and what are the circumstances that have sort of brought them into hospital? And also, what are the other risk factors that I have to think about in terms of potential risks for the intended recipient? But the main question I really ask myself is, if this person donates their organs, am I going to use them? Because as a transplant professional, not only do I have a duty of care to the recipient, but I also have a duty of care to the person who's kindly or their family have kindly consented to donation on their behalf. And what none of us like doing is putting somebody through a big operation at the end of their life for no benefit to anybody. In terms of recipient factors, there's lots of things to think about. I've just put a few of them on this slide. The main things we think about, I think, are how long has this person been waiting? How unwell are they? Could they possibly wait for something else or not? How complicated is this person, either anatomically or immunologically? How likely are they to get another offer? Is it going to be better or worse than what I'm being offered today? Is this organ going to be adequate for this recipient? And are there any other factors that I have to think about that may lead to complications or difficulties? And ultimately, are the benefits of transplanting this organ greater than the risks? And as you can see, there's a lot of questions on that slide and not necessarily lots of answers. But the main question is this the right thing to do? And obviously, as doctors, we like to do the right thing for our patients. So there's a huge amount of uncertainty, not only for the patients, but also for us as well. In terms of other factors, I thought it was probably just mentioning this, that actually transplantation is logistically extremely challenging, especially in terms of timings and working out who to transplant, when, in what order, where the organs are coming from, what time they're going to be retrieved. And sometimes these challenges can mean that we have to sometimes turn certain organs down, or we have to ask for retrievals to be delayed. Especially in the COVID era, for example, we have to think about whether we can safely transplant people, whether we have side rooms available, intensive care beds available. And sometimes we do have to think about these things when we're offered an organ. And unfortunately, there are instances where sometimes we do have to say no. When you put all of that together, I think the questions are, am I transplanting the right organ into the right person at the right time? And obviously, I tried to get as many of those things correct as possible. In terms of the challenges, I think one of the things that's always at the forefront of my mind whenever we're thinking about especially deceased donation is that I think people who are waiting a transplant can potentially be quite vulnerable. We as transplant professionals sell transplantation as a good thing to do, because of its advantages or in terms of survival and also quality of life. And from the recipient's perspective, I imagine this is a day that's been very much longed for, and there's a degree of desperation and wanting to come off the waiting list and to get on with your life. And as a result of that, I think expectations are understandably quite high. And I really don't want to make things worse. And unfortunately, no transplant is risk-free. And as Gabby will talk about in a little while, we often refer to a crystal ball, and unfortunately none of us have got a crystal ball, and we can't predict necessarily exactly what's going to happen to that person once they have their transplant. In terms of shared decision making, I think there's 2 bits to this. The first thing to say is that actually it's very rarely one person in the transplant team who is making all the decisions. Often organ offers are discussed between lots of different people. We have a duty of care in terms of shared decision making with patients, to communicate information accurately in a format that the patient understands. And I talked a little bit last week about risk communication and how this is perhaps an area that we need to maybe improve on. It's also our duty to provide accurate and honest answers to questions and to be realistic about what the outcomes are likely to be. Without having a crystal ball, sometimes that can be quite difficult. And it's important not to make any promises. It's very, very rare that any of us can sit down at the end of somebody's bed and say, I promise you it's going to go well. I can be as sure as I can be, but I can't promise you anything. And sometimes it is really complicated. Sometimes donors are complicated, recipients are complicated, and there are instances where none of us really know what the right thing to do is. But I think the main message that I would like to say to patients is that any perceived uncertainty or hesitancy on our part is not driven by either a desire to just transplant for the sake of it or to go home early and get a good night's sleep. It's really driven by the desire to do the right thing and to make life better for that person. And very rarely is there anything else in anybody else's, in a transplant professional's mind. So from a patient perspective, what can patients perhaps do to facilitate the decision making? I think this is something that deserves some thought even before somebody's put on the waiting list. I think it's important for patients to think about what type of organs they're happy to accept in terms of risk profiles, age, comorbidities. I think patients should be encouraged to talk to us and to ask questions, and also understand that if they say no to something, if they're not sure, then that's okay, and that they shouldn't be penalised or punished as a result of that decision. Ultimately, it's your body, it's your life, and if you're not happy taking on a particular risk, then you shouldn't be forced to. And I think it's also really important that we understand the patient perspective, and hopefully that's something we will get some insight into today. So on that, I will finish and hand you back to our chairs.
Thank you so much, Hannah, for your great discussion. It has been wonderful to be share this perspective from the 3 different points. From the donor perspective, the willingness to respect this will and gift for the society, the best interest for the recipient, and as well how all the process is influencing in this important decision. We have one question from the participants, very short question, please. We are a little bit delayed. Nissan is asking to all the panel, how often do professionals adopt a conservative approach due to their own anxieties rather than real risk to the patient? Can you please clarify?
I think that's a very reasonable question. Sometimes you get a gut feeling that you're not happy, and sometimes that's very difficult to shake off. And if you come up with a problem, you always kick yourself and think, I shouldn't have done that. And I think sometimes having a gut feeling is a good thing. But I do understand how that can sometimes maybe put barriers up and stop us from doing things that maybe we should. But I think being a surgeon and having that level of comfort in what you're doing, I think there's a huge amount of importance that comes with that as well.
Okay, perfect. Gabi is telling, Gabi Oniscu is telling that he likes to make a brief comment, or later, Gabi?
Probably later. I think Nizam has raised a good point, and it is important that your own anxieties usually come from experience and previous cases that you've seen. And time and time again, I guess we have to take stock, because we will make a decision based on the most recent experiences, and if those are negative, you'll be naturally more conservative. And I think this is where it comes, that interaction and discussion with other colleagues puts that mind at rest and actually helps you make the right decision.
Very well point. Create multidisciplinary teams. We can go back to that. Please, we need to continue. Thank you so much, Hannah. Thank you so much, Gabi. We need to continue with Daniel Gallego. Daniel is from Spain. He was recently elected as the president of the European Kidney Patient Federation. Previously, he had been president of Ulcer Federation. Since 2018, is the Federation, Spanish Federation for Kidney Disease here in the country, and he has been involved in numerous other groups working to improve the core outcomes of the standard outcomes in nephrology. And in addition, he's Secretary of Social Social Impact and 2030 Agenda in the Spanish Confederation of the People with Physical and Organic Disabilities. Great activity and related with your life and all this initiative. He has been collaborated as well with other steering groups related with kidney disease and health condition and active patient programs, Global Home Dialysis Roundtable and Advisory Board of Patients in Antimicrobial Resistance Council. So Daniel has been a kidney patient since 1993, undergoing hemodialysis since 1995, and he received a transplant in 1998, but unfortunately it failed in 2003, coming back to hemodialysis. So Daniel has a lot of experience in all this, going and going back, and then it's always great to have you here with us. Thank you, Daniel. Please go ahead. The floor is yours.
My pleasure and a privilege. Thank you, David and Peter, for inviting me, and all the ESOT team. Of course, well, this is the name of my presentation. Let me gain words, because of course I have the responsibility to share with you in only 10 minutes what is the uncertainty and the offering and to accept an organ. I don't have any conflict. What we see of a transplant is only the peak of the iceberg. When you see a transplant person, you behind of the transplant, before, during, and after, there is always the uncertainty of what is going to happen. So the patient journey, as David has said, especially if you are young, maybe you are candidate to one or more transplant in your life, because especially in kidney, we have only 12 years of average of duration. So you are going in and out of transplant and dialysis, and of course we need a social protection by law to protect with these programs of reintegration this life that you are in and out of the laboral market. And sometimes we have seen a lot of inequities in transplantation and access to transplantation. Of course, we are not ready for this uncertainty, so we need these social programs to peer-to-peer programs. We are always saying that the professionals give you the news, but the patients give you the truth. So this is more or less what is going on in the mind of people, because this is an unknown journey, and we have to tackle and address these emotional disorders. And we need to talk, of course, before and after the surgery. We need to understand how is the waiting list, because it's not a normal queue. You realize it's not depending on age, or it's not dependent on time or years. It depends that is suitable for you, and there is a lot of biomarkers that depends of that. You will be ready for the decision. You can be a donor even despite the COVID-19, because we have a special situation now, but the transplantation is following despite this situation. But of course, it's always a reversible process. You can remain in the waiting list saying no, or this is the most important thing, that you can remain on the waiting list despite your decision. And we have in kidney a special waiting list here for the autoimmune or hyperimmunization, especially if you have received several transplants. You have a immune process that we have in a special list that maybe will be your option. And we have in kidney both types of donation. We have from the deceased donor. The waiting list process, it takes time, it takes several times, but you still remain in dialysis, and maybe you are years of waiting, because but luckily we have dialysis, but only 20% of end-stage kidney disease in dialysis are suitable to be included, so to be transplanted. So waiting list and transplant is a kidney transplant is a great opportunity. We have seen that elderly people are donors, so we have all kidneys for young people, and maybe the donor health is a concern for us, and you have to be aware that there is a process to check all the health for the donors. From the living donor, always the responsibility is to ask for a kidney, because we have a lot of concern about the donor, because you are living only with one kidney that remain to another person. So the donor health is again a great concern, because we are claiming for a living donor leave as the mothers to take several weeks to recover the health from the living donor. So this is more or less what you have to be aware about these things. And of course, the responsibility is to try to improve the skills of the accepting a kidney, because you are living, of course, a kidney for the health of one person. You are leaving the donor with only one, but you have to. The key of empowerment of people is not only information, it's education. So we have to improve the skills to the self-caring and management of this transplant about years, to try to be to have the independence and to try to be the autonomy. And as I like very much this concept about the co-responsibility. You don't have only the responsibility as a recipient, we have the co-responsibility with this multidisciplinary team, with the professionals, the family, the donor, and the recipient. And this is the real 5-step decision-making process in the market. Luckily, we don't have to purchase nothing, but of course, when you need a transplant, you have a need, and you have to do an information search and evaluate all the alternatives to remain in the waiting list, or to say no, to say yes. But you have to choose, and you have the options to share decision making with a real partnership. But the most important thing is to feel comfortable with it, with the decision. Nobody should decide for you. And of course, after receive the organ, you have to evaluate if you are lucky or if you are good with the decision. But it's quite clear for me that we need to talk. Because health are conversations, so we need to talk before, after, and during the transplant. Because with education and motivation and interviews, maybe we can improve this uncertainty and these feelings of the responsibility to accepting an organ. We need to create a multi and interdisciplinary team, not only with the kidney professionals or the liver professional. We need to talk with the patients organization, with peer-to-peer programs, and share our fears and our concerns to try to avoid this uncertainty. And you have to be in mind that you'll never walk alone, because with this partnership, you are always with people that's giving you support of professionals and patient organizations, and always let the donor take the decision. Not only the recipient has to decide, maybe the donor has to do the decision, because the transplant is the best always replacement therapy for you. And of course, family is always a therapeutic element itself. So please share your concerns and your feelings, and how is your emotional today, to try to avoid this responsibility. And thank you very much for your attention. And maybe after we can share more questions and doubts.
Thank you very much, Daniel, about explaining this complex perspective, which is a patient's view on this issue. And I completely share with you that there is such a need for knowledge and understanding in order for us to be better at this shared decision making. And I appreciate it very much. In the interest of time, I'm going to ask everybody to ask the questions to Daniel and the other panelists in the Q&A part of which you can see at the bottom of your screen, and we'll come back to you, Daniel, later. And with that, I would like to introduce our next speaker, which is Gabriel Onyescu. He's the director of Edinburgh of the Transplant Center. You saw him earlier answer one of the questions. He couldn't help himself, and I'm glad for that. He's a clinical interest in liver, pancreas, and kidney transplantation, as well as laparoscopic surgery, as well as polycystic kidney nephrectomy. And he's also a special research focus is organ perfusion, reconditioning, and transplant outcomes, as well as optical sensing. And he also happens to be the secretary of the European Society for Organ Transplantation, which is called ESOT. Thank you very much, Gabriel, and the floor is yours.
Thank you, Peter, and for more than generous introduction, and good evening, everyone. I think it's quite important to consider that patients expect us to have a crystal ball, and sadly we don't. And our job as clinicians is to try and maximize the outcomes by reducing uncertainty and providing the patient with the optimal information at the right time. Accepting an offer is clearly a fine balancing act, and really we need to consider the risk of the patient acquiring either an infection or a cancer from the donor, for example, balanced against the risk of dying on the list whilst waiting, or the risk of disease progression, which may put the patient outside the waiting list. To illustrate how important it is, the press and the mass media is full of cases that illustrate the challenges for the clinicians to make such a decision. And I think most eloquently, the patient has put it there that nobody should really fight someone else's cancer. To illustrate some of the challenges that we face, let me just show you one potential offer. And I won't go in the details in the interest of time. Everything is perfect except the last line. The donor in this sad case had a previous Duke's C colon cancer 8 years prior to becoming a donor. And what that means really is that the cancer has spread to the local lymph nodes. So that immediately sends alarm bells for the clinician. And I think the question here is, what are the main issues that we faced? And usually this is in the middle of the night. You may have expected issues, such as in this case, or unexpected at the time of organ procurement. You clearly may want to get more information about this story and to try and understand the depth of the problem and what risk this brings to the potential recipients. But information may be somewhat limited. And furthermore, this is compounded by the fact that you may not have time to gather that information. And this is much more critical for cardiothoracic organs, but also for liver transplantation. And ultimately, and very importantly, we need to understand what does the patient want, or what is our understanding of what the patient want. So our job as clinician is very much to reduce uncertainty, and this is a very complex process. And in this particular scenario, you would have to go back to the history, understanding exactly all the nuances in the history of the disease that the donor had, try and get information from pathology, look at all the investigations, contact a friend or more, consult on the available guidelines, and also discuss with your colleagues who may come after you to do the transplant. Once you get on the information and you have a provisional acceptance, and you look at the careful information that you may get at the time of organ procurement to maximize your degree of confidence to go to the patient. The consultation process is complex, and here's an example of potential people and information we may want to get in touch with prior to making a decision, which range from the information provided by the donor coordinator, really up to the governing body in that particular country, to try and make sure that are we doing the right thing here? And that's a key question. Are we not doing something silly? We have a number of guidelines that help us decide or inform us better about the risks in any given situation. And those could be at the international level. On the left side, you see the European guidelines and some of the UK ones that guide my particular practice in Edinburgh. But ultimately, the key question from a clinician, and this comes back to the point that was raised earlier in the question, whose responsibility is to decide whether an organ is usable or not? And in the UK, the surgeon undertaking the transplant bears ultimate responsibility. But again, like it was said before by Daniel, we are not walking alone, and we're walking with our colleagues to try and share the information and the burden, because it's not a decision that we can take lightly. So if you think about perspective, the healthcare professional has to respect the patient decision, and our duty is to inform the patient as much as we can and support the information, support them with the right information. We need to consider the patient and their particular circumstances, and also the system, and consider what they might get and what would be the prediction of the next liver offer that may or may not come. So if we go back to the case that I've showed you earlier on, how would you reduce the uncertainty? So again, a lot of information needed. So we understood that curative surgery and chemotherapy undertaken 8 years prior to donation. We understood that the disease were limited in its spread. We had some sort of confirmatory data from the previous scans that there were no evidence of cancer spreading. You can phone the colorectal surgeon, so the bowel cancer specialist, the oncologist, trying to understand what is the implication of that disease and the stage as presented. And you discuss with your hepatology colleague to understand whether this patient requires transplant or not, or can wait potentially for a different organ. We look at the guidelines and then we make a decision. And in this situation that I've shown you, the risk of transmission through a transplant was somewhere in the region of 0.1 to 2 in 100. Okay, so what do we do with that information? Well, actually, we then go to the patient. And I think it's important to pause first and consider that consent and discussion of any risk is not a single day process. It's actually a continuous process. 3 o'clock in the morning when an organ is offered, it's not the right time to discuss this with patient, because they will think about other things. Am I going to live? Is the operation going to be complicated? And so on. And therefore, the risks should be discussed at the time of assessment in daylight and revisited. In my own practice, I tend to use scenarios like the one I've shown you to understand the risks and certainly ascertain the risk appetite of each patient. And I'm also cognizant of the fact that risk appetite may change, and particularly for liver transplantation, as there's no alternative treatment when the condition deteriorates. And always reassess, always additional discussion at the related to the donor, such as this one. There's risks related to the recipient. This risk related to the organ specific, the quality of the organ, and risks related to surgery. So the communication with patient has to take a pros and cons of that individual offer. In this situation, we would offer a timely transplant, and we balance the risk of transmission, 2%, versus the risk of dying on the waiting list, up to about 8%. And also, by deferring that offer, there's an unpredictable challenge at what the next offer may bring, because as Hannah said, all of them are second-hand organs. And of course, against that, you will wait longer. Risk is not zero. And if transmission occurs, the limited options are available. We then need to consider what are the alternative treatment options. And sadly, for liver transplantation, there aren't many. And there's an inexorable way and progression to death as the disease progresses. But our responsibility as clinicians is very much to provide the best possible information to allow the patient to make the optimal decision at that moment in time. So in summary, what do we do when we don't have a crystal ball? Well, actually, we need to do the best to create this beautiful picture and a wonderful outcome for the patient. I think the duty as a clinician is very much to leave nothing to chance. We need to leave no stone unturned, so then we can go to patients and have an open and honest discussion with the best available evidence that we can provide. We clearly need to listen to the patient, and this is a conversation that takes place over many, many consultations, because we're in this together trying to get the best outcome for each individual patient. And I think each donor offer should be considered on its own merit, but we need to understand the risk appetite of the patient, and this should be reassessed on the list regularly, because in the case of liver transplantation, as I said, sadly, there are no alternatives, and we should look at them individually. Thank you.
Thank you so much, Gabriel, for this nice presentation. It presents the idea that you are not alone. It's a complex process, and especially it's a journey. It's not starting on the last day when you have the offer. It's becoming like a process that started in the previous webinar. We have a question, but please, Yelena Stojanovic, we will be delighted to answer at the end in the Q&A. Just in terms of time. So please, Gabriel, we will have this question later. Be alert for that, and thank you so much. And I would like to invite, please, Angelica Wilhelm to join us. Angelica got an hepatitis C virus infection following a blood transfusion in the early 1970s. In 2008, she has a last-minute liver transplantation, and after 3 attempts of interferon therapy, her hepatitis C infection was cured in 2014 with the new direct antiviral agents. She's the founder and president of the patient organization Hepatitis Aid in Austria. It's a platform for healthy liver and the largest umbrella organization in Austria. And she has been the vice president of the European Liver Patient Association for 8 years, and is now a board member of the New Liver Patient International Association, where she is responsible for transplantation. Her primary interest has been patient advocacy, liver disease, including rare liver disease and liver transplantation. And in 2018, she became the president of the Austrian Association for Patient Advocacy and Support, an umbrella that grouped all the patient organizations in Austria. Please, Angelica, welcome, and thank you so much for your talk about Lesson from a Patient Transplant Journey, a wonderful talk and title for this perspective. Thank you, Angelica.
Thank you for the invitation to be a part of this panel and to share the patient perspectives. Principle, I agree with all previous speakers. It's wonderful to hear your things and so on. I can say I have no conflict of interest to declare, and I would like to present to you as an example in my journey of a patient that went through an organ transplantation. I am liver transplanted in the year 2008, and so on and so on. You have heard it. Today I will not talk a lot about why I needed an organ, but so you know, I suffered from viral hepatitis for 30 years, did all the treatments available, and was cured with the new DAAs 5 years after my transplantation. That is another long and important story, but today we focus on the journey of receiving an organ. First, let me tell you a bit about the situation in Austria, because I'm coming from Austria, and it is not uninteresting to hear something from Austria. The situation is rather good in Austria from a systemic point of view. Please, the slide. Thank you so much. Austria is opt-out, meaning everybody is a donor unless they explicitly disagree. Generally speaking, if somebody in Austria needs an organ, there is a good and a realistic chance to receive it on time. But people aren't really aware of that. And there is no real awareness work done in Austria. We need that really, really urgently. Please, the next slide. Thank you so much. If people receive an organ, they aren't really sure if they should share it with the public or no, or not, even though it's almost normal in Austria to donate or receive organs. People aren't confronted by it at all. So even though we actually have something like a best case scenario, experienced doctors, working system, working laws, there is a lot of work still to be done to avoid discrimination. This is very urgent, and the resulting reluctances in offering and accepting organs. As a result, nobody is in any way or form prepared for the sentence, "You will need a new organ." When you hear a sentence, the entire world changes for you completely. Next slide, please. Next slide. Thank you. Thank you. It is important to mention this. Being put on the transplant list is a big chance not everybody gets. A chance to go on, and in that situation you need to be aware of this and grateful for the fact that you are in the position where it is still possible to do something. Then all the questions arrive. Will I survive? Will I change? Will I hurt? How does the operation work? Will I feel it? And should I even do it? And hope for more life. And then starts the waiting period and more questions once again. Next slide, please. You cannot imagine what it will feel like this. Getting a new tooth is easy. Most know the feeling of weirdness after the dentist when he puts something new in your mouth, but this is different. An entire organ. How will it feel? Will it change me? How much? In what way? I'm prepared enough for this? What if I miss the call? And then you get the call. And that, from this moment, your life is completely changed. You hear a quiet voice. Hello, we have an organ for you. Do you want it? Do you want to keep living? Are you ready? Oh, of course. It is not asked like that. But this is what it feels like when the call comes. Next slide. In an ideal world, because this is a big, scary step, you would know to the surgeon personally. That is a really important thing, to know the surgeon personally. In some cases, you don't know the surgeon before the operation. You want to know who does this to you, and you need to trust them. I called my family's member, and let them know it's happening. It's happening tonight. The ambulance drove me and my husband into the hospital. I was prepared for the operation the whole night. I was shaking on my whole body. I wished they would give me anything to relax, even if they would told me it's a placebo, anything to calm down. And I felt left alone because I didn't. Next, but it's difficult. A long operation, but it is a difficult and a long operation. So they actually can give you something to calm down, but you wish for it. When I was in the operating table, I was secured for operation, and I felt like being put on the cross. One arm for the trip and the other also secured. And I thought, can't you wait with that a few minutes until I'm completely out? You must know that I'm scared of being operated, of not waking up. But then you go under and you wake up. In a room with many nurses and doctors, you are realizing it worked. I'm alive. And the thoughts start again. Better? Yep. The new organ is now in me. I don't feel different, but am I? Is it like the movie Alien? There is somebody else inside me, partially. You start to communicate with the organ. Try to feel it, accept it. Then slowly you realize somebody died. Not because of me, but somebody died for this, for me. And that makes you very sad. And you start to think, the organ is helping me now to live on. When you realize all this, you are immensely grateful to the doctors, the hospitals, the nurses, and especially the donor. My husband, a mechanic, helped me think about it in a certain way to understand what happened to me. Here, if one part of a car breaks down, you replace it with another used part. And the whole car works again. And it is still the same car. It is still you. Today we try to exchange our experiences from different perspectives and then hopefully improve the situation for everybody. Next slide, please.
Angelica, could I ask you to round off shortly, since we are a bit out of time?
Yes. I need only one point. I have few things I would have wished for during those times. One, I would need psychological support from the moment I was put on the waiting list, because nobody is ever prepared it. Also, family and household members should be included. There are lots of options on how to do this, but it is needed. Doesn't matter if it's in the hospital or on your GP or a patient association, but you should be put into the care of somebody who works with the topic professionally. Next slide. Also, I would need one contact point, one point of care I can come to with anything a medical manager. If I would be told in advance that there will always be one telephone number, it would have made my journey much easier, almost like a guardian angel. There needs to be a one contact point that has all medical data that you can reach anytime for all medical questions. For example, I had last year an accident, and then we had many troubles. And ideally, this one point of care is set up in a way that uses all the informations gathering for science and research and makes it available for the healthcare system. Now, enough of my wish list, and I hope I could give you a look behind the curtain on what it feels like to receive an organ and give back to you, Mr. Karstedt.
Thank you, Angelica, and I can very much relate to that sentence you said, that the world stops when you are asked or you're told that you need a transplant. I myself had 20 years to prepare, but I had not been able to prepare, and that's, I think, one of the bigger issues. Thank you, Angelica. We will now move over to the Q&A session, and I would like to invite all the panelists to turn on their cameras, and we will look at the Q&As that have been provided. And my suggestion is that we will take just 2 questions in the interest of time. And I will actually try the first one that was asked by Jelena, the question is, in how much detail do you discuss organ offers with adult recipients? And I think we could include a next question is talking about marginalized organs, for example. What level of information should be included in that discussion? And I think maybe Hannah and Gabby could be the first to respond, and then I would also like to have Danielle's and Angelica's perspective on that as well.
Well, I mean, I think it's quite difficult sometimes to know exactly how much somebody wants to know. And our legal obligation is often to present information that, to be transparent and to present information that we think is going to influence whether or not somebody makes a decision or not. I don't know how you feel about it, Gabby. I mean, I'm fairly happy telling patients a lot, but I'm very cautious that I don't want to overwhelm them. And I have to obviously be very careful about not only what I say, but how I say it. and how the risks are communicated. And as I mentioned in my talk, I think that's one area that perhaps we need to focus on, so that actually it's not just a case of reciting information and someone on the other end just nods. It's how that information is not only retained but understood and then used to make a decision.
It's very well to what you talked about, Gabi, about the continuous process of receiving that consent, and I mean I thought that was a very interesting aspect. But could you please also relate to that? How much information should be given, and at what point, of course?
I think as much information as the patient needs really to make the decision, because Hannah's right, not every patient will want the same level of depth, but that can be ascertained well ahead of the offer. You know, that's part of the continuous education and consent process. I think one key element here we need to mention is that we cannot disclose information about the donor that are particular, but actually there's a lot to make that decision that needs to be taken. So essentially anything that's out of ordinary needs to be discussed with the patient, because it may have implications that we may not be aware, quality of life or different implications. And I think that's important for the patients to have everything to make the decision that they need. But that decision is at that time, not what if, what may. It's relating to that offer at that particular moment.
And Danielle, if I may ask you, do you see any good examples or cases where you see that this continuous learning process is working really well? Because it's a complex issue that both you and Angelica talked about. There are a lot of emotions and issues, and each patient has a different level of being able to receive this information. And you are not receptive at one point, but you are at a later stage. And maybe Danielle or Angelica has some examples of where it works really well, and that would be interesting for us to hear about.
Yeah, absolutely. As Hannah has mentioned, the situation is unique and the person is unique. So the level of information have to be adapted to the level of questions and sometimes the information is given you at once, or you feel that the information is given you at once, and you have questions at home. So this is an ongoing process that we need to talk, of course, before and after and during, and you have to share all your feelings and all your thoughts or your concerns, because this is the key point, that we are not ready, and we have to try to scan and search all the alternatives, all the information, and don't feel that you're a number, as Angelica has said, because sometimes you can feel it, no? That you are only a number, and this is the protocol, and this is the information given to you, and that's it, no? This is not the thing that we would like to have. We are claiming for an ongoing process and this multidisciplinary approach.
Thank you. Angelica, would you like to add something to that about good examples of how that works well?
Yes, I agree completely with Danielle. We need really many times for all information to give all informations to the patients, but we need many times, and you cannot give each patient the same information. You have to talk with him on his level, and that's really important. And you have to also to talk with the husband and with the family and so on, because I couldn't imagine before my transplantation has been that this was so an extremely problem, or however you can say, for my family. It was and we had a time. It was how can you say it?
A big topic.
With a big topic, yes. To be careful and take many time to talk with the family and the donor. At the moment, I have a case. There is a man coming to me in my center and said, "Oh, all doctors said to me, I will be a transplant. I will be a transplant patient. I shall say yes, and next week I will have the next meeting with the doctor, and then I have to say yes. But I know nothing. I have no idea. I feel I fear for it. Please talk with me and say what shall I decide. And this is the negative. This is absolutely negative. So it should not be.
That is absolutely
Not
great,
enough
Angelica.
time. Yeah.
Yeah, that is absolutely great, and you are totally right. And in terms of time, we should now finish the Q&A, and just we would like, together with Peter, to congratulate to both of you, Angelica and Daniel, and as well to Gabby and Hannah, to join us for this adventure in this webinar. You know that there are a lot of questions. Many patients have been participating with us, and together, professionals and patients, we need to work together and to have a sharing decision. And this is the main point. It's a shared decision. As Angelica points, it's not a point only for the decision of the physician. It's to involve the family and all the people around the patient, and educating and follow them all the time, not wait only on the last day. And then we invite all of you to join for the TLJ 2.0 and to join us for the next journey. You can see in this slide that this has been a journey that started more than 1 year ago with the Survey of Patient Association, a meeting with all the patient association in the last meeting in Copenhagen. And then we started again with this process to involve all the patient association with us and in ESOT and with all these webinars. And we invite you to join for the next TLJ for all these important point about concerns about uncertainty. And we would like to thank all of you for your kindness to be so patient for this hour working together with us. So register for the TLJ. You have a special fee available for all of you and for all, not only patient association, but as well health professionals. You are very welcome to join us. Thank you. Peter?
And I would also like to say just a concluding remark is what patients want and what the professionals want is the same thing. It's to reduce the uncertainty, and I think that's been very clear from all the panelists here tonight. And we all want to receive or to give the best available option, and I think that's what this dialogue and this process and this learning journey is all about. So I would also like to thank you all here. You can look at the playlist that was just on the screen, but I would also invite you to look at the website for the Patient Inclusion Initiative, which you can find a lot more about this. And I would also, the final thing, I would like to ask if you could follow out this the poll about what you thought about tonight's webinar, because we also want you to give us feedback. But this quick poll is: was this helpful? Was this webinar worth your time? Was it extremely helpful or not very helpful at all? And that's up to you, of course. For me personally, it gave me new perspectives and also reinforced perspectives that I've heard in previous talks. So please fill that out in the quick poll that we have. And then I would also invite you to, of course, give us feedback if you have ideas or tips about how we can proceed in working on this. And I can tell that most of you who filled this out thought it was very helpful or extremely helpful, which is, of course, we're very happy.
Wonderful, great. We are very happy. Thank you so much.
And with that, we'd like to thank you for tonight, and hope to be seeing you in the learning journey that is just about to start. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Thank you to all the people. Bye.